Hello there, I'm Amy Clark. I'm a medical oncologist at the University of Pennsylvania, and I have the pleasure of giving you a breast cancer update today. I'm going to start by talking about breast cancer basics to make sure that everyone, including the patients in the audience as well as the providers, are on the same page with the lingo that I'm going to be using. And I'm also going to break down the updates by receptor status because that's really what drives our treatment decisions. We know that there are over 200,000 new cases of breast cancer diagnosed annually in the United States. Most of them, 95% of patients initially diagnosed with breast cancer, have curable breast cancer. Unfortunately, about 30% of those with curable breast cancer will go on to relapse. And right now, we think of stage 1 through 3 breast cancer as being curable, but stage 4 breast cancer or metastatic breast cancer is not. We really treat stage 4 or metastatic breast cancer like a chronic disease, which I think is important when we're thinking about the trial outcomes. When we think about breast cancer, the most important thing that we can think of is the receptor status. These are proteins that are expressed on the surface of breast cancer, and we look for the expression on every single breast cancer that we diagnose. Those three proteins are the estrogen receptor, or ER, the progesterone receptor, or PR, and the HER2 new protein. These are both prognostic and predictive. ER/PR positive HER2 negative breast cancer is by far the most common kind of breast cancer. About 15 to 20% of newly diagnosed patients have ER/PR HER2 negative or triple negative breast cancer, and about 15 to 20% have HER2 new positive breast cancer. When we think about what are the clinical and pathologic risk factors of breast cancer recurrence, we think of size of the breast cancer, so the bigger the cancer, the more likely to recur. The number of positive axillary lymph nodes, again, the more positive axillary lymph nodes, the higher likelihood of recurrence, as well as the receptor status, with unfortunately triple negative being the most aggressive. Let's talk about breast cancer lingo. I'm going to talk about 3 different types of treatment, and I think it's important to understand what I mean. So the first is adjuvant. Adjuvant treatment is treating the cancer after surgery at the initial time of diagnosis. These treatments are generally either chemotherapy, anti-hormone therapy, anti-HER2 therapy, or radiation therapy. When I talk about neoadjuvant therapy, I'm talking about treating the breast cancer before surgery at the time of diagnosis. And really here, we focus on chemotherapy and anti-HER2 therapy, although occasionally anti-hormone therapy is used, but I'm not going to be focusing any of my discussion today on that. When we think about the treatment goals and the clinical trial endpoints in adjuvant therapy and also neoadjuvant therapy, I think the most important goal is to improve breast cancer survival and prevent distant breast cancer recurrence. Another way of saying that is to increase the number of people that we cure from breast cancer. Clinical trial endpoints, therefore, focus on recurrence. So invasive disease-free survival is a very commonly used endpoint. And that means that means how many patients have either a recurrence in the breast or outside of the breast of breast cancer or get diagnosed with a brand new cancer after a given treatment. There are also some unique goals of neoadjuvant therapy, and therefore the clinical trials also focus on a couple of other endpoints. One of the most important goals of neoadjuvant therapy is also enabling simpler surgeries. So that could mean shrinking the breast tumor to allow a patient to have a lumpectomy rather than a mastectomy. That could mean eliminating cancer from the lymph nodes to enable removal of fewer lymph nodes. That could mean making an inoperable cancer operable, meaning that depending on where the location is, it could be attached to the back of the chest wall, and the surgeon can't automatically just remove that. It's also prognostic, though. So we know, particularly for HER2 positive and triple negative breast cancer patients, that the amount of cancer at the time of surgery really can help to predict the likelihood of recurrence. And therefore, in some patients, we can add some additional therapy if there is cancer left over. And in other patients, we can give less treatment after surgery because there is no cancer left over at the time of surgery. So important clinical trial endpoints are the rate of what we call pathologic complete response, meaning the rate of cancer clearance from both the breast and the lymph nodes. Invasive disease-free survival is also another very important endpoint. When we're talking about metastatic breast cancer, because remember I said it's not curable and we really treat it like a chronic disease, the goals are different, and therefore the clinical trial endpoints are also different. One of the main goals of all of our treatment, of course, is to prolong life, but not only prolong life, but to prolong good quality life. So improve symptoms for metastatic disease, optimize the quality of life. And therefore, clinical trial endpoints really focus on what is the response of the cancer to the treatment, so response rates, or what is the benefit, the clinical benefit rate, meaning not only how many tumors shrunk, but how many tumors remain stable for a long period of time. Progression-free survival, or how long someone is on a given therapy before the cancer progresses, is another important endpoint, as well as overall survival, meaning how long patients live with breast cancer. So let's start by talking about ER/PR positive, HER2 negative breast cancer. I'm going to be focusing on two topics. One is to whom we give adjuvant chemotherapy, and the other is a relatively new topic, which is adjuvant CDK46 inhibitors. So if we think about the history of chemotherapy and early stage breast cancer, in the beginning, it was really just surgery, actually, was the main way that we treated it. Then tamoxifen came around, we started giving anti-hormone therapy. Then we figured out that chemotherapy was effective. Then we figured maybe we can give even more chemotherapy. And we even looked at doing autologous bone marrow transplants in the 1990s, to see if we could really give maximal doses of chemotherapy to eliminate breast cancer. During those days, chemotherapy was recommended basically to all patients who had a breast cancer greater than 1 centimeter or who had positive axillary lymph nodes. However, what we began to understand was that it's probably not about the size or the number, but it's also about the biology of the cancer, and that the biology of the cancer may actually trump either the size or the number of lymph nodes. And that's where genomic profiling comes into play. Genomic profiling really helps us understand who needs chemotherapy and who does not. So the most common genomic profiling that we use in early stage breast cancer is called the 21 gene recurrence score. This examines 21 genes in the breast cancer cells themselves, and each cancer gets a unique score based on how over or under expressed those 21 genes are. And that score helps to predict the response to chemotherapy and also prognosticate, or it estimates the risk of distant recurrence at 9 years. Initially, this test was validated in a set of tumor samples that had been saved from a clinical trial in which patients either received chemotherapy or did not. Initially, it was thought that those with low risk had a low oncotype, so 1 to 17, no benefit from chemo, so it was not recommended. Then there was the high risk group, anyone who had a score over 31. Chemotherapy was beneficial, and therefore it was given to everybody. But the group in the middle, the intermediate risk, there was unclear whether or not chemotherapy was beneficial. And so the TAILOR-X trial was actually designed specifically to look at this group of patients who had a score, a 21 gene recurrence score in the middle. So actually over 10,000 women participated in this trial. And if their score was super low, they did not get chemotherapy. If their score was 26 or above, they did get chemotherapy. And everyone who had a score in between got randomized to either receive chemotherapy plus endocrine therapy or anti-hormone therapy, or an anti-hormone therapy alone. And essentially what they found was that chemotherapy was not beneficial or useful in those who had a recurrence score under 25. They did an exploratory analysis and actually did determine that there could be a potential benefit in patients under the age of 50 or likely premenopausal. And so it's still unclear always whether or not we should be using this, whether or not we should be giving chemotherapy to patients who are premenopausal or at the very least under 50, who have a recurrence score between 16 and 25. I think it's important to understand though, remember, this was done in women who had negative lymph nodes. So the question is, can we extrapolate these results to patients who have positive lymph nodes? Because retrospectively, we have examined patients in other clinical trials, and found that there could be a role for the recurrence score, but this had not been prospectively validated or studied. So what was recently presented was the Respondrx trial. And this trial looked at patients with 1 to 3 positive lymph nodes, ERPR positive, HER2 negative, and and allowed patients to get a recurrence score. Those who had a score over 25, everyone got chemotherapy. However, patients with a score of 0 to 25 were randomly assigned to either receive anti-hormone therapy alone or anti-hormone therapy after having received chemotherapy. Importantly, they did specify ahead of time that they would actually do some subset analyses to look at people with very low scores, 0 to 13, versus people who had slightly higher scores, 14 to 25, thinking that it's possible that there could be a range of benefit, and perhaps it's the very low people with a very low score that did not have would not have a benefit versus the people who are in the middle that might. They also predefined that they were going to assess the results by menopausal status. So our Responder goals. The main goal was to determine the effect of chemotherapy on invasive disease-free survival in patients with 1 to 3 positive lymph nodes and a recurrence score of less than 25. So remember that IDFS is recurrence either locally or distantly of the breast cancer or a new breast cancer. And they would assess whether the effect depended on recurrence score and whether there was a different effect depending on menopausal status. So when you look at the results, you can see when you look at the results by menopausal status, this is postmenopausal women. It doesn't take a genius to see that there are 2 lines that look pretty similar to each other. So in other words, meaning that there is no difference in those who got chemotherapy versus those who did not. However, when you looked at patients with premenopausal breast cancer, you actually do see that those lines separate. So you actually want the line to be as high as possible because that means fewer events, fewer recurrences. And so you can see that over time, and the follow-up is at 9 years, that there are fewer recurrences in those who received chemotherapy versus those that didn't. And you can see the 5-year difference in invasive disease-free survival. The absolute difference is about 5%. Importantly, this mostly was driven by distant recurrences, meaning that actually the benefit of chemotherapy was that it prevented distant recurrence. So again, remember that they specified that they were going to look at the group with the super low recurrence scores as well as those in the middle. And you can see again, when you look at the postmenopausal patients, when you grouped them together, there was no difference. And even when you separate them out by recurrence score, there still isn't a difference, meaning that regardless of the score of what the actual numerical score is, those who have a 21 gene recurrence score of 25 or less do not benefit from chemotherapy. However, when you looked at in the premenopausal patients, you can see that actually, regardless of the recurrence score, there is a benefit from chemotherapy, and that benefit is higher in those who have a higher recurrence score. So in those who have a recurrence score of 0 to 13, there was an absolute difference of recurrence of about a little under 4%, versus those who have a recurrence score of 14 to 25 who might have a recurrence score, who have a difference in invasive disease-free survival of over 6%. So I think it's really important then to conclude that postmenopausal women with ERPR positive, HER2 negative breast cancer with 1 to 3 positive axillary lymph nodes with a recurrence score under 26 or 25 or less can safely forgo adjuvant chemotherapy. Woo, that's great. I also think, though, that in premenopausal patients with ERPR positive, HER2 negative breast cancer with 1 to 3 positive axillary lymph nodes, those patients do benefit from chemotherapy. It decreases distant recurrence. It improves the number of patients that we cure in that patient population. And therefore, the 21 gene recurrence score should not be used in premenopausal patients with 1 to 3 positive axillary lymph nodes because all of them benefit from chemotherapy. Now let's talk about another group of patients, and that's those patients who have a higher risk breast cancer, and talk about some new drugs that are you see pretty heavily advertised on TV, the CDK46 inhibitors, and talk about two trials that examined two different CDK46 inhibitors in locally advanced early stage breast cancer. I put this picture up here just to remind you sort of what CDK4 and 6, what the heck they do, and what CDK46 inhibitors do. So I'd like to mainly focus on the circle or the cell cycle diagram that's on the left side of the screen. This is sort of bringing you guys back to basic, high school biology. So we know that all cells, including cancer cells, go through the same growth cycle. There's a growth phase, that's G1. It then goes into S phase. That's where gene replication or DNA replication happens. Then it goes into another growth phase, and then M phase is mitosis, when the cells split, and then they all go back into G1. CDK4 and 6, along with a protein called cyclin D, regulate a very important tumor suppressor gene called the RB protein. The function of RB is actually to prevent gene replication, to arrest cells or keep cells in this first growth phase. So one of the hallmarks of cancer, as we all know, is overproliferation. And so RB can be inactivated in certain cancers, and therefore there can be gene replication that's sort of out of control. So interestingly, this whole pathway is also regulated by none other than ER/PR and pathways. And so there's crosstalk, what we call crosstalk, between the hormone receptor pathways and the CDK4/6 pathways, such that the ER and PR depends on the CDK4/6 RB pathway to enhance cell proliferation. So in the metastatic setting, these drugs have been approved and are given with endocrine therapy and double or triple the progression-free survival of metastatic breast cancer patients. There are 3 drugs in this class: palbociclib, ribociclib, and abemaciclib. I will just say that abemaciclib is also approved to be given alone after progression on prior therapies. They are very well tolerated, so the main side effects being low blood counts for palbociclib and ribociclib, and diarrhea for abemaciclib. So because these drugs are, as a class, so effective in metastatic disease, and because they're relatively well tolerated, the next logical question is, can the addition of these agents to anti-hormone therapy in the adjuvant setting prevent recurrence of the disease? So 2 trials, there's actually 3 trials that have been designed. One is still ongoing, so hasn't reported, but there were 2 trials that were presented within the past 6 months that have looked at this question, but they have different results. So Monarchy and Pallas. Monarchy added 2 years of abemaciclib to anti-hormone therapy, whereas Pallas added 2 years of palbociclib to anti-hormone therapy. Both had primary endpoints of invasive disease-free survival. Both randomized over 5,600 patients to the trial. But Monarchy is a positive trial, meaning there were positive results, whereas Pallas is a negative trial, meaning that they didn't see a difference in those who got palbociclib versus those who did not. So I think it's important to understand a little bit more specifics about the trials, and then we'll talk about why this might be. So if you look at the study design of Monarch-E, we have hormone receptor positive, HER2 negative, node positive, high risk early stage breast cancer, okay? So patients were assigned to one of 2 cohorts based on their clinical pathologic risk factors. So anyone who had 4 or more positive lymph nodes was allowed on the trial, regardless of how big the primary cancer. Patients who had 1 to 3 positive axillary lymph nodes were allowed on the trial as long as the tumor was grade 3 and was greater than 5 centimeters. They also allowed a group of patients onto the trial if their biomarker called Ki67 was greater than 20%. Ki67 is a biomarker that looks at cell proliferation. It's a little bit controversial because not all people, not all pathologists are trained on how to actually read Ki67. So it turns out that there's a lot of variability. But nonetheless, they were patients who had a centrally tested Ki67 greater than or equal to 20% were allowed. Patients were randomized to either standard of care endocrine therapy or abemaciclib with endocrine therapy. And this was, of course, after patients had received any chemotherapy that the treating physician felt was appropriate. So here you can see results that were presented last month at San Antonio. The bottom line is that there were, at 2 years of follow-up, there were fewer recurrence events noted in patients who received abemaciclib and endocrine therapy compared to those who received endocrine therapy alone. I've highlighted here the actual numbers because it can be a little bit difficult to read this. So in the red group, that's the patients who received abemaciclib, 92.3% of patients had not had an invasive recurrence at 2 years versus 89.3% of patients in the endocrine therapy alone group who had not experienced a distant recurrence at the 2-year mark. Oh, and then I will also mention that they also had fewer distant recurrences in patients who received abemaciclib. So it's not only a decrease in local recurrence, but importantly, fewer distant recurrences. Now let's look at the PALLAS study design. It's very similar, but they're not as specific with some of these clinical pathologic risk factors. So stage 2 to 3 hormone receptor positive HER2 negative breast cancer who had completed their appropriate adjuvant treatment, adjuvant chemotherapy, were allowed to enroll. And they did allow node negative and smaller tumor sizes, so stage 2A. And patients were randomized to receive palbociclib for 2 years along with endocrine therapy or endocrine therapy alone. And as you can see here, both for invasive disease-free survival and distant disease-free survival, those lines are right on top of each other. And what that means is that there is no difference in the two treatment groups. Now, really importantly, one of the things that was noted about the PALLAS trial was that 55% of patients required a dose reduction of palbociclib at some point during treatment. But also, 42% discontinued palbociclib early, but only about 27% were due to side effects. Further, among those who stopped palbociclib due to side effects, only 62%, so a little over half, were at the lowest dose of palbociclib, meaning that they could potentially have received a further dose reduction. And so I think what really this led the investigators to question is, could this high rate of discontinuation or impact the outcome of the trial? In other words, could this be an effective drug? It's just that people couldn't actually take it or didn't take it for as long as they were supposed to. So at San Antonio, the investigators presented a poster that looked at exposure of palbociclib and outcomes in PALLAS. This is called a landmark analysis. So they evaluated both the duration of palbociclib as well as the exposure intensity of palbociclib. In other words, how long people were on it, as well as the dosing that they actually received. And the bottom line is neither intake duration or exposure intensity made a difference in the results. It was still negative. So this leads to the question of, why is monarchy positive while PALLAS is negative? Well, one explanation could be that there were more high-risk patients in monarchy compared to PALLAS. The proportion of patients with 4 or more positive lymph nodes was higher. It was 60% in monarchy, where it was only 37% in PALLAS. And so it's possible that because PALLAS is a lower risk population, there just aren't going to be as many recurrences. It turns out that we wonder if it could also be that is it because of how these two drugs, abemaciclib and palbociclib, are dosed. Abemaciclib is a continuous drug, whereas palbociclib is intermittent. It's taken for 21 days in a row with 7 days off. So could that somehow be affecting whether or not it can improve invasive disease-free survival? Could it be that one drug is just better than another? That's a possibility, although when you look at the data in metastatic breast cancer, we really don't see a huge difference in the efficacy of these drugs. They're very effective in most patients. And one question that had been raised is, could the high discontinuation rate of palbociclib on PALIS be the reason that that's a negative trial? And I do think that investigators did a very thorough job of looking at that question. And I think we can confidently say that the high discontinuation rate of palbociclib on PALIS was not the reason it's a negative trial. And therefore, we'll just need longer term follow-up to understand really whether there is a benefit at all. So let's conclude the ER positive HER2 negative update by just summarizing what I've talked about. Not all postmenopausal patients with 1 to 3 positive lymph nodes will benefit from adjuvant chemotherapy. The 21 gene recurrence score can help with decision-making on who gets chemotherapy and who does not, but premenopausal patients should still be recommended chemotherapy because premenopausal patients with 1 to 3 positive lymph nodes do benefit from chemotherapy. And I think also another conclusion is there could be a role for abemaciclib in the adjuvant therapy of high-risk breast cancer patients. This is not yet FDA approved. I know that it is being examined by the FDA. And I think, remember, it's still only 2 years of follow-up. So we need a lot more follow-up to understand, will it continue to decrease the number of recurrences or will it become ineffective at some point? And we also need longer term follow-up of PALIS to understand if there's any benefit to palbociclib. Let's move on to talk about updates in HER2 positive breast cancer. And in this arena, I'm going to talk about 3 new drugs for metastatic disease. The 3 drugs are trastuzumab deruxtecan, tucatinib, and margetuximab. So let's start by thinking about HER2 breast cancer biology a little bit, because I think that helps us understand why these HER2-directed treatments are so important. If you look on the left of your screen, you can see that a normal cell has a HER2 protein on the cell surface. But what can happen is that if it is overexpressed, it sends too many growth signals to the cell to grow and can cause cancers. So we have, on the right of the screen, a number of very effective treatments that block this very strong growth signal from the HER2 protein so that can halt proliferation. We have trastuzumab and pertuzumab that are antibodies or proteins that are directed or specific to the HER2 protein. They basically are given and attached to the HER2 protein and block the signal that it gives the cell. TDM1 is an antibody drug conjugate, and we'll be talking about a new antibody drug conjugate in a minute, so you'll understand what that means. And then there are other small molecule inhibitors tyrosine kinase inhibitors called lapatinib and neratinib that work inside the cell on the inside of the receptor to block growth signal. And when we think about the mechanism of action of these new HER2 targeted agents, I've circled the ones that I'm going to be talking about, but I'll just highlight that you can see that there are several others that are in the works. Margetuximab is an antibody that works to, it's a souped up trastuzumab molecule, and I'll talk about that, what I mean in a minute. There's DS8201 that or trastuzumab deruxtecan, that's a new antibody drug conjugate. And then there's tucatinib, which is a tyrosine kinase inhibitor that again works on the inside of the cell. So trastuzumab deruxtecan is an antibody drug conjugate. What I mean by that is that the antibody of trastuzumab has a proprietary drug linker, so meaning that it's engineered to have a mechanism that we can attach a chemotherapy to. And so literally what it does is it goes into the body, it finds the HER2 positive cells, or the ones that are overexpressing HER2, and it directly delivers chemotherapy to them. So Destiny-1 examined trastuzumab deruxtecan, or DS-8201, in pretreated HER2-positive metastatic breast cancer patients. To be eligible for the trial, patients had to have HER2-positive metastatic breast cancer, had to have prior treatment with TDM1, and they allowed brain metastases. About 184 patients were enrolled on the trial, and there was an average of 6 lines of prior therapy. So that's a pretty large number of prior therapies, and about 10% of patients had brain metastases. What they found was a surprisingly high response to trastuzumab deruxtecan. 60% of patients had at least 30% shrinkage of their tumor volume. This is amazing in a patient population that has had so many prior therapies. And essentially, all of the subgroups that they looked at benefited from trastuzumab deruxtecan. The average time on therapy without progression was over 16 months. And I think one of the things they recognized throughout this early phase trial was that it can cause something called interstitial lung disease, or ILD. And in some cases, because before they knew how to look for it, it was fatal. So that's a potentially, obviously, bad side effect. And they've done a very good job as the drug has gone into further clinical trials of trying to much more carefully screen for that and to stop therapy much sooner if a patient develops this potential side effect. So 13% is a high rate. We're not seeing that in clinical practice, but nonetheless, I think we'll have a better understanding of what the true rate of interstitial lung disease is as this goes through more trials. So while there's an impressive response rate in patients who have received a lot of therapy, the phase 3 study that is really comparing trastuzumab and single agent chemotherapy to trastuzumab deruxtecan is currently ongoing, although it's not accruing in the US anymore because the US approved DS-8201, or trastuzumab deruxtecan, for metastatic disease. And investigators or clinicians have to work up patients for interstitial lung disease for any symptom that could even remotely seem like it could be interstitial lung disease. And because there were so few patients on this trial who had brain metastases, it's unknown at this point whether this drug is effective in patients with brain metastases. So let's move on to talk about tucatinib. So tucatinib, just to remind you, is a tyrosine kinase inhibitor, and it works inside the cell to block growth signals. The HER2 trial randomized patients with HER2-positive breast cancer to receive trastuzumab with an oral chemotherapy called capecitabine with placebo or tucatinib. Eligible patients had at least 2 lines of prior therapy for metastatic breast cancer. And importantly, patients with brain metastases were eligible, and there were specific endpoints built into the trial to assess response specifically of the brain metastases. So the bottom line that you can see from these two curves that I'm showing you are that adding tucatinib to trastuzumab and capecitabine lengthened time to progression and helped improve overall survival, or in other words, helped patients live longer. That is amazing, okay? That alone is a win. However, it also delays progression of brain metastases. And this is really the first time that we have seen a drug so effectively delay progression of brain metastases. Brain metastases is something that is a particular problem in patients with HER2-positive breast cancer. And so having therapies that enables us to treat patients with brain metastases more effectively is really wonderful. Importantly, there was an increase in diarrhea and liver function test abnormalities in patients who received tucatinib, and so those do have to be monitored closely. And so I would just conclude by saying that tucatinib is effective in combination with trastuzumab and capecitabine, and is effective at delaying progression of brain metastases compared to those receiving placebo. Importantly also, compared to those receiving trastuzumab and capecitabine alone, those who receive it along with tucatinib stay on treatment longer, meaning they respond longer, and they actually live longer. So I think that tucatinib is going to be very commonly used in combination with trastuzumab and capecitabine. And I can tell you that it's already being investigated much earlier on in treatment to see if it can actually prevent development of brain metastases. And finally, let's talk about margetuximab. Margetuximab is a fancy trastuzumab. So it's actually the top part of the Y there is the trastuzumab molecule that recognizes the HER2 protein. The bottom part of it actually is a specially engineered part called the FC protein that is engineered to stimulate the immune system. So in other words, it not only targets HER2, but it also is trying to rev up the immune system to enhance effective treatment. The SOPHIA trial was a trial for patients with 2 or more lines of anti-HER2 therapy for metastatic breast cancer who may or may not have had prior brain metastases. And patients were randomized to either get trastuzumab with one of 4 chemotherapies, the oral chemotherapy capecitabine, an IV chemotherapy eribulin, an IV chemotherapy gemcitabine, or an IV chemotherapy called vinorelbine. And patients were randomized to receive one of those chemos along with margetuximab or trastuzumab. Now, it was up to the investigator to choose which of those 4 treatments the investigator or the treating physician felt was appropriate. And the primary endpoint was progression-free and overall survival. The bottom line is that margetuximab with chemotherapy is better than trastuzumab with chemotherapy. The SOPHIA trial enrolled 536 patients, and there was a 24% decrease in the risk of progression in those who received margetuximab versus those who received trastuzumab. And the clinical benefit rate was higher in the margetuximab group. There was a similar set of side effects for both groups, although more infusion reactions in those receiving margetuximab. So what are the conclusions here? There's 3 new exciting drugs. Tucatinib is effective in treating brain metastases, which is extremely exciting. Trastuzumab deruxtecan has a high response rate in patients who have received a lot of prior treatment, but it's very important that if you are going to be receiving this drug or giving this drug to a patient, that you watch out closely for any signs of interstitial lung disease. Finally, margetuximab in combination with eribulin, vinorelbine, gemcitabine, or capecitabine improves response over trastuzumab with chemotherapy and should be used in later line treatments. Let's conclude by talking about the updates in triple-negative breast cancer. And here we're going to be talking about immunotherapy as well as a newly approved drug. So I think immunotherapy is a very hot topic in cancer oncology in general, and we see these advertised on TV quite heavily. But there's a very specific rationale for immunotherapy in triple-negative breast cancer. And I've put a picture on the right here just to sort of give you a graphic of what I'm talking about. So if you think of a cancer cell, so this is sort of the gray cells that you see in a clump there. Cancer cells express cancer proteins, right? And the immune system should be able to recognize these cancer proteins as foreign and then eliminate them. But cancer cells figure out mechanisms to hide from the immune system, both by decreasing expression of those cancer proteins, but also by increasing expression of PD-1 on the surface. What that does is it recruits cells in the immune system to actually help the cancer hide from the rest of the immune system. And some triple-negative breast cancers have tumor-infiltrating lymphocytes, which are quite abundant. And so it's felt that potentially these types of cancers may be more prone to respond to immunotherapy than others. Finally, there's also drugs that are available to inhibit both PD-1 and PD-L1, so inhibit that interaction with those cells those immune cells that are helping to hide the cancer cell from the immune system. And there are 2 that are approved in breast cancer, atezolizumab and pembrolizumab. So just to give you a very brief summary of how we use it right now, immunotherapy is approved in metastatic disease along with albumin-bound paclitaxel, which is a kind of chemotherapy. The addition of atezolizumab to albumin-bound paclitaxel delays progression of disease and prolongs life. Other chemotherapy in patients who have PD-L1 positive immune infiltrates. Other chemotherapy partners are under investigation, but I think really the question is, since we view triple negative breast cancer as being more aggressive, right? A lot of focus needs to lie on early stage disease and how can we prevent recurrence. So can immunotherapy be one of those new therapies that helps to improve response in the neoadjuvant setting, to improve response rates, and help the number of people that we cure? So the KEYNOTE 522 study was a study designed that randomized patients to receive standard neoadjuvant chemotherapy with pembrolizumab, followed by 27 weeks of pembrolizumab, or chemotherapy alone, plus placebo, followed by a placebo infusion. So it's important that this was an international trial, and so the chemotherapy was, there were a couple of different regimens that were allowed. Um, this trial used 4 chemotherapies. Some people only use 3, so I think that is important to recognize. But I think the point is pembrolizumab was given with each dose of chemotherapy, and it was given by itself as a single agent after surgery for 1 to 9 cycles. And the bottom line is that I've highlighted here the group of patients with a PathCR. Of the 401 patients who were randomized to receive pembrolizumab with chemotherapy, 260 or 64.8% had a pathologic complete response, compared to the 201 patients who received placebo with chemotherapy, of whom 103 or 51% had pathologic complete response. That's an absolute difference of 13.6 that was statistically significant, meaning that there was a much better response, or there was a higher number of patients who had no cancer at the time of surgery in the patients who received pembrolizumab versus those who did not. So at 2 years of follow-up, there's a 30% decrease in recurrence in those patients who received pembrolizumab. So it's not only that it improves the number of patients who have a pathologic complete response, but it also improves the number of patients who recur. There are some important side effects. So this seems like a slam dunk, but the immunotherapies come with a cost, and that is that they can overstimulate your immune system to actually attack itself, attack normal organs in the body. What we saw more commonly in those who received pembrolizumab on KEYNOTE 522 was hypothyroidism, or low thyroid levels, and that happened in 13.7% of patients who received pembrolizumab versus 3.3% of patients who did not. And importantly, adrenal insufficiency, although not common, is actually a really important, not well recognized side effect of these immunotherapies, happening in 2.3% of patients who received pembrolizumab versus 0%. Now, these are the numbers of the adverse events or the side effects that happen during chemotherapy. We have not yet seen reports of the adverse events that happened afterwards. So these numbers actually could be higher since patients received pembrolizumab for up to a year. So what are the conclusions? There absolutely may be a role for adding pembrolizumab in those with triple negative breast cancer receiving neoadjuvant therapy. It not only increases the pathologic complete response rates, it decreases recurrence at 2 years, although again, it comes at the cost of the immune-mediated side effects. I know that this is being reviewed by the FDA. It is not yet FDA approved to be given in this setting, and longer follow-up is needed to understand the impact on cure rates. Will it continue to improve cure rates, or is it delaying recurrence? That's what we don't know, and that's what we will find out with longer follow-up. Finally, let's talk about a new drug called sacituzumab govtecan. Sacituzumab govtecan is another antibody drug conjugate. Irinotecan is the name of the chemotherapy that is attached to an antibody to a protein called TROP2 that is expressed on triple negative breast cancer cells. There was a phase 1 trial of sacituzumab in triple negative breast cancer patients. 108 patients enrolled with previously treated triple negative breast cancer. The average number of prior therapies was 3, although the range, meaning the absolute lowest and the absolute highest number of prior therapies, was 2 to 10, so some patients were pretty heavily pretreated. Impressively, about a third of patients, 33.3% of patients, had a complete or partial response, which means either there was no evidence of cancer on the scan, or there was more than a 30% reduction in tumor volume on the scans. And responses happened quickly within 2 cycles. The patients were on therapy for an average of 7.7 months. Common side effects that were seen in those who received sacituzumab were low blood counts, in particular neutropenia and anemia, the GI side effects of nausea, vomiting, diarrhea, and also low electrolytes or low salts in the blood. And that's something that would need to be monitored, in particular low phosphate levels, which is not something that is typically checked on a regular basis. So this is now being investigated in earlier settings, in phase 3 trials, but I think is definitely something that now investigators can use as a treatment to help patients with triple-negative metastatic breast cancer. So I think I want to leave you today with the following conclusions. We are developing tools to tailor therapy to the individual, both by more effective treatments for HER2-positive breast cancer, more effective genomic tests to understand who needs chemotherapy and who does not in the early stage ER/PR-positive, HER2-negative breast cancer setting. And we're developing better drugs that can help breast cancer patients live longer and live better lives. And so although I can't stand up here and say that we have a cure, I'm going to say that we're actually much closer to a cure. And I think the outlook for breast cancer is much brighter today than it was last year. Thank you so much for listening.